All right. So scanning the breast. Let's see. Breast is, this is kind of strange. It is a modified sweat gland. Ew, I mean, so what were like the first breasts like if it was just a modified sweat gland? So I don't know. Modified sweat, modified sweat gland. And I don't think it's a, oh, you know what, I have some lines for this. Let me, where'd you go? There we go. Okay, let me just follow my notes in order. I think we all know what this is. So to start, we're kind of, I think we're starting from the outside and working our way down. Obviously, dead center is the nipple. We all know about that. And then around the outside of the nipple itself is the areola. It has a slightly, depending on your skin tone, I guess, a different color than the rest of the skin. And there are bumps on there. Those are actually called Montgomery's gland. The Montgomery's gland is a sebaceous gland, and what it does is puts oils onto the nipple, and that is important during nursing because the baby has a tendency to dry skin out and cause damage to the skin. So Montgomery's glands are sebaceous glands. In other animals, there is a scent so that puppy dogs and piglets and whatever, whatever is you're thinking about, whatever mammary gland, whatever mammal you're thinking about, there is also a scent that comes out of these sebaceous glands so that they can find them blind, because a lot of animals actually are born blind. And so the scent helps them find them. Montgomery's gland. Cooper's, well, if I follow my notes, okay, well, this breast does not show Cooper's ligaments. And it is down here, though, so let me just go ahead and I'll just write down here. Cooper's these are what hold the breast together, that hold its shape. So on this image, we have an arrow going to a single Cooper's ligament. It goes from the skin level. So I guess, no, that top picture does not show any Cooper's ligaments. It goes from the skin level all the way through the breast to the back of the breast, along the back fascia plane of the breast. And it holds the breast in shape. And what we're going to find is lobules are in between Cooper's ligaments, or Goober's ligaments, whatever. So the breast has varying amounts of fatty tissue versus fibroglandular. So fibroglandular, that's going to be the operating system, the milk producing part of the breast, and the fatty tissue is just there for looks, I guess. So as we go down through the breast tissue, the very first part of the breast tissue is the pre-mammary layer. Well, actually, we start with skin. Let's just, obviously, that's the first part. And then we have the pre-mammary layer, and that's basically fat. Subcutaneous fat, subcutaneous meaning below the skin fat. And then the next layer is the important layer, the mammary layer. So that is your glands. And then let me jump over to this side if we're going to stay in order of my notes. Retro mammary layer, and once again, fat. So pre-mammary, mammary, retromammary. And you will see part of the Cooper's ligament system is they travel along. Cooper's ligaments also travel through. And there's kind of a back fascia layer here. Let me finish up with what we have here. Oh, I meant to put, because I actually have, I have the bracket here. I meant to put that down here because up here, I was just going to call that a lobule. That's okay. Not the worst thing in the world to mess up. So the mammary layer, yes, the entire glandular layer. Let's see if I can just do this from memory. Well, ribs. Kind of important to note, actually, what ribs are, what they look like, because many a sonographer has confused a rib for a lump or something seen on ultrasound. And when you get up, there are certain parts of the ribs, as you get closer to the center of the chest, they go from bone to cartilage. Cartilage looks very different on ultrasound than bone. And so sometimes people are not accustomed to seeing that, and they see it and they go, oh my gosh, what is this? Let's see. Two muscle layers here. Pectoralis minor. Pectoralis major. So here's the major, minor, obviously a rib here. Chest wall. Basically back here you're in lungs, so you're not going to see anything. Let's come around to the front here. I guess I just meant to write lobe. Breast has multiple lobes, each with multiple acini and ductal units inside of each lobe. Oh my gosh, lactiferous duct. So as these ducts come in, I'm just going to go ahead and I'll write and we're going to talk more about this. Lactiferous duct, or how about this, question mark, sinus? Because what happens in the lactating female, all the ducts increase in size, but the sinus especially increases in size. And this basically, this area underneath the nipple acts as a reservoir for milk. And so these sinuses fill with milk. Oh, that's what letdown is. When women talk about, breastfeeding women talk about a letdown, that's it, milk coming out of the lobules or the lobes into the sinuses. I got nothing else to say about Cooper's ligaments at the moment. Okay. Let me look at this again. I feel like we went, we're going to talk about it. We're going to talk about this again, obviously, under ultrasound appearances. Well, here. Here we go. Fibro. So the part of the breast that we're most interested in is the fibroglandular tissue. That's where cancers begin. Actually, cancers begin in these guys right down there. So we'll talk about that. But it is composed on the largest scale of the breast, 15 to 20 lobes. Each lobe has 20 to 40 TDLUs. That is terminal ductal lobular unit. Sorry, I put down my notes. I had ductal and lobular as one word. I was like, what the heck did I write? Terminal ductal lobular units, TDLUs, and that is where cancer occurs. So we have to talk about a little bit about that. The smallest functional unit in the breast within the terminal ductal lobular unit, the smallest functional unit or structure, maybe I could say, is the acini. The acini, just like lung acini, or gosh, where else do we talk about acini? Oh, the pancreas as well. Just a very small structure with an epithelial cells around the outside and creates, in this case, milk in other cases. So this is your mammary gland is an exocrine gland, just like the pancreas is an exocrine gland, but of course that creates pancreatic enzymes, but same kind of structure on a microscopic level. Okay, so let's look at, let's zoom in on this guy a little bit here. So all of this, we have lobule, but all of this is within a lobe. Remember those 15 to 20 lobes, each with 20 to 40 TDLUs. So, okay. TDLU consists of an intralobar terminal duct. So there is considered a duct word terminal here. Then you have the extralobar duct. Here to here. These become lactiferous ducts. And these are all traveling, of course, towards the nipple. The whole point is to create milk and bring that to the nipple. So as these all come together, actually, let's just use. So 15 to 20 of these guys, the actual lobes. Inside of each of these lobes are multiple, many acini and 20 to 40 TDLUs. So TDLU is here. The intralobar terminal duct, the extralobar terminal duct, ductules, and then on a smaller scale, but actually not shown here, the acini are in here. So the acini drained in the ductals drained into the okay, let's write that down. Acini, ductal, intralobular, no, that's right. Intralobular, extralobular, and then they go to the larger lactiferous. Ducts. On a non-lactating patient, the ducts should be less than 2 millimeters. Lactating, obviously, we're going to have larger ducts. Those could be upwards of 8 millimeters. Let's see, where am I going? Where do I write this? Okay. Actually, let's just use this right there. Perfect. So the TDLU inside the lobe, inside the mammary layer, is where most of our tumors are going to develop. The majority, most cancers upper, outer quadrant. So, gosh, I mean, we kind of have to define that, don't we? Hi. Good Lord, it looks like a dolphin or something. One last time. Fine, there we go. Okay. So the patient is facing you. This is the right breast. This part actually, it's called the tail of Spence. We'll talk about that in a moment. But the breast tissue goes up a little bit towards the patient's axilla, their armpit. Majority of cancers upper, outer quadrant. Of course, this would be the upper inner quadrant, lower inner quadrant, lower outer quadrant. But most cancers are up there. The reason most cancers are up there majority of gland tends to be up there as well. We'll mention, I wish I drew a better picture of this. This is extension of breast tissue called the tail of Spence. That travels up towards the axilla on the right and left, of course. I'm going to read. You know what? Next thing should be vessels. I'm not going to talk about the vein. The veins are basically they follow the arteries. They basically they have the same more or less distance or travel is along the arteries. So the lateral thoracic artery, this guy down here, it's also called the mammary, right? Lateral thoracic feeds the right side of the, the lateral part of the breast. On this patient, it'd be the right side. Obviously, on the other side, it'd be the left side. But the lateral part of the breast. The medial is from the internal. That reads internal thoracic right here. These are the two major arteries of the breast. A couple of arteries that are not shown. Well, one kind of important artery, it's a somewhat important artery, comes actually from up top. The thoracoacromial, that's an R. The thoracoacromial artery feeds the top of the breast. And then the very bottom of the breast, oh darn, I don't have, the book didn't have it either. I'm sorry guys, I don't know that. It's a very minor artery anyway, we don't need to know it. Idiot, I thought I wrote it down. Okay. The breasts, obviously drawn by a man. Okay. So breast cancer, sometimes the first indication that there is a breast cancer is not so much the lump, but a lymph node, let's say a number of lymph nodes in the axilla or the armpit are increased in size, which is alarming. The breast is drained from the nipple radially. So drains out, drains out, drains out. Most of our, most of the lymph goes to, they go to, well, I just say, all right. The axilla is the number one. Drain of lymph. So when we do an ultrasound, it's of the breast, and then you pretty much, you're always travel up into the armpit a little bit. The whole way up, you're looking for any kind of lymph node that is increased in size. There are some small nodes within, that's interpectoral. I guess I should have taken a closer look at this. Well, in any case, you can have small lymph nodes within the breast. They can be a little bit disconcerting because most of the breast is lymph node free, but you can run into a lymph node, and it's just important to be able to recognize that that is what it is. Like I said, majority of lymph goes into the axilla. Some of it goes into the peristernal. Some goes into the pectoral or Rotter's nodes. So that is not a breast node that should be within the pectoral muscle or around the pectoral muscle, just anterior to it. Supraclavicular nodes, so they will drain all the way up to here. Some drain to the opposite breast, which really confuses things. And some will drain down into the abdomen. Now, in general, you're not looking for abdominal nodes. You're not going to the opposite side. If you've been asked to look at the right breast, you do not look at the left. And generally, I mean, we're going to talk more about the actual ultrasound exam Wednesday, I guess. No, tomorrow, because we're putting vascular on hold. We'll talk about more about the exam tomorrow. But just so you know, ultrasound is not the first imaging modality, unless it's a young woman and they don't want to do chest x-rays, well, obviously mammograms, because those are, they can cause cancer eventually, right? From the radiation. So ultrasound obviously is non-radiating. So young women with a lump, sometimes ultrasound is the first thing to go, or the first modality they go to. You generally do not scan the entire breast because we do not go on fishing expeditions. And it's actually, and I got yelled at pretty viciously from a very nice doctor. He was viciously angry with me though, because the ER doctor requested a breast ultrasound for a lump, and really it was more of a surface lump. But I was not registered in breast, nor was I at a location where we were doing breasts, nor was I at a location, and it was during the weekend, I didn't even have a radiologist present. So he was furious, because if you miss cancer, there's a high, the doctors get sued a lot. So, and also obviously this is patient's health we're worried about. So just so you know, if you ever get a breast exam out of an ER, call your radiologist first. They will allow some exceptions, like if they really suspect an abscess, you could do an ultrasound. If they are wondering if it's cancer, you do not do it out of the ER. They must go to an ultrasound or a breast clinic to have their ultrasound done. Very important. And so we don't go on fishing expeditions. If there is a specific area where they say that the patient feels a lump in the, let's say, the upper inner left breast, then you can scan that. Not out of the ER. You're working somewhere that actually does breast exams. You can scan just that area, kind of that area alone. If it's just, the patient just wants a breast exam, but the doctor doesn't want to do a mammogram because they're young, generally it is not our job to scan the entire breast. Because once again, mammography is number one. And it's number one for a reason. It sees more, although we're better at characterizing a small mass. We could do a better job at saying it's this, it's that. And so a lot of times, very many times, mammography sends it to ultrasound. But mammography is much better at finding the needle in the haystack. They find everything because everything is in the picture. Granted, they can miss something, but if they miss it, you'll probably miss it too. And if you start with ultrasound and we're not as good at finding the needle in the haystack, it's just not a good idea. Anyway, I'm starting to ramble here. Okay,